we have two distinct types of data about the non-VKA oral anticoagulants. First, data that comes from large clinical trials, and secondly, data that comes from registries. And these data are of different quality, and they give us different kinds of information. I'm going to turn to Paulus Kirchhoff and ask him to describe the issues of how we mix and match with this kind of information.
Thank you, John. It has been only 25 years ago that the vitamin K antagonists have been introduced as agents for stroke prevention in AF patients through controlled clinical trials. And I think it is important for this entire discussion to keep in mind that only properly designed randomized clinical trials can actually inform us about the effectiveness of a given treatment. And we've seen tremendous progress, and I just want to use this one slide, although there are many others that show similar things, to summarize that. This is a slide that summarizes the recommendations published by different guideline writer groups in Europe, in the US, and in Canada. And it simply shows three things. First of all, patients with valvular atrial fibrillation should be treated with vitamin K antagonists. This is the far right part of your slide. Secondly, almost everyone with AF, when they have two stroke risk factors, and that those can be summarized by the Charles-Wask score, is eligible for oral anticoagulation. So giving them a blood thinner that will predispose them to bleeding will prevent more strokes than it will cause harm, and this is recommended across the Atlantic. And fortunately, we have different choices. We have the vitamin K antagonists, and there are 4 or 5 in use in Europe, and we have the novel direct non-vitamin K antagonist or anticoagulants, if you want to use all the different ways of describing the acronym, as an alternative. And the ESC and the Canadian Cardiovascular Society have moved forward first to say that they should actually be preferred based on clinical grounds. We have a small number of patients, those without any stroke risk factors, that don't need anticoagulation, and we have about 5 to 10% of the patients with AF that only have one of those stroke risk factors, where we are not entirely sure, based on the clinical trials evidence, what to do. And you can see all the dotted lines in that flow chart that the different guideline writing groups came up with slightly different recommendations. But overall, the picture is clear and based on a lot of good evidence. Now, what type of clinical trials evidence do we have? First of all, we have evidence from the BAFTA trial and from the Averroes trial that aspirin does not prevent strokes in AF patients. More importantly, from my view, aspirin causes the same amount of severe bleedings in the BAFTA trial, shown in this hazard ratio plot graph here, than a vitamin K antagonist, warfarin, does. And aspirin causes the same amount of severe bleedings than one of the NOACs, apixaban, does in the Averroes trial. So that when we have to decide between aspirin and an anticoagulant, we have the choice between 2 treatment options that are of different effectiveness, and the anticoagulants are more effective, but that cause the same risk of bleeding. When we look at the new oral anticoagulants, or the NOACs, then we have 4 landmark trials that have been published. And this is a flow chart shown from, or this is a chart from a meta-analysis of these 4 trials. And it clearly shows that there is a benefit in terms of safety, and especially when we look at intracranial hemorrhage, that the NOACs cause less intracranial hemorrhage than the vitamin K antagonists in these controlled trials. And also that there is less of a risk for hemorrhagic stroke, which is slightly overlapping, at least to some extent. And that the effectiveness is about the same, with one, I think, notable exception, that there is a 10% mortality benefit in patients that were randomized to the NOACs in the phase 3 trials compared to the patients that were randomized to vitamin K antagonist. And these considerations are the basis for the recommendations of the guidelines writer groups. Now, what can we say about real-world data? And obviously, if you want to look at how new agents are used in the real world, you have to wait until they are approved and until they are introduced into the different healthcare systems. And therefore, what I will show you now are initial data on the first take-up of the NOACs, but they can only be a first glimpse, and we will probably need some more time to get a fuller picture of their use. This is data from a registry called Garfield, and the striped bars in the middle show you the number of patients that were treated with NOACs in this cohort of about 10,000 patients. And you can see that it's about 5% of the patients that were treated with a NOAC, and about 60% overall were receiving anticoagulant therapy. Clearly an undertreatment when you think about what we just heard about in the guidelines and from the randomized trials. This is another piece of information that was just recently presented and published in August of this year. And it shows that the majority of patients, and this is from a group of about 2,500 patients that were followed by the ESC EORP team, that the majority of patients who are on a vitamin K antagonist at baseline remain on a vitamin K antagonist afterwards, 84%. And the majority of patients who were on a NOAC at baseline remain on a NOAC afterwards. Fortunately, in view of the undertreatment of many patients with AF, we can see that quite a few of the patients who were treated with antiplatelet therapy alone have picked up an anticoagulant, either a vitamin K antagonist or a NOAC, after a year. And this is probably one of the trends that can explain why in another registry, and this is from a European registry that was that has reported in 2013 and has recorded treatment information in 2012 after the publication of the guidelines that we have just heard, that the adequate anticoagulation choice is actually made in about over 80% of the patients, rather than the 50 to 60% that we have been used to before. And the contribution of the new oral anticoagulants here is again between 5 and 10%. And you could argue that this is less than you would expect if you had sort of an ideal computer choosing after an ideal guideline algorithm. But when you think about how patients are treated and are continued to be treated, that may actually be just the beginning of the true uptake of NOACs. And I think there are many impediments and regulations in the use of all types of medications, not the least our own habits, that can explain this relatively low number. And with that, I am done with my introduction, and I look forward to the discussion.
Paulus, thanks very much for introducing the issue of registries versus clinical trials. That's possibly not the right way to think about it. It's not really versus one another. I think both of them provide different quality of information or different types of information. What do you think the main purpose is for the registry data?
Well, I think, first of all, they are a required and important sequence. Without phase 3 trials, you don't get a new medication or a new intervention approved. And without approval, you cannot study its effects in registries or in real-world data. And I haven't shown the data, but they can also be healthcare database based. The importance of clinical trials is not to be underestimated. There is no way to get around the information on effectiveness from a controlled randomized trial. But many patients are not enrolled into trials because they don't meet the inclusion criteria, because it is not convenient for them to participate in a trial, because they don't want to participate in a trial. Furthermore, the treatment reality in a controlled clinical trial is to a certain extent artificial. Due to monitoring, simple things like pill count are provided for every patient, which has a huge impact for adherence for our topic. And therefore, I think that we will gain. And then, an important thing is safety when it comes to idiosyncratic or rare events. Rare side effects of new treatments will never be picked up in phase 3 trials, because you need to expose a few 100,000 people to the treatment before you pick up the signal. And all these things, safety, effectiveness in a general healthcare setting, but also the adequate use. is the intervention actually used in the indication that it was intended for, or is it just used for other things, can be very well answered by registries and healthcare database information.
But of course there's always a problem in the sense that the registry is rarely controlled properly. You usually have experience with a single drug. Sometimes you can have multiple drugs, but certainly there's no randomization within a registry usually, although some people would like to do randomized trials within registries. And it's difficult somehow to put it in proper perspective when it comes from a registry.
Yeah, but in my view, strategies that work well in randomized controlled trials should also work well in registries. If there is a discrepancy between the two, then I think there is something wrong with the trials in the first place. And what we see now with the NOACs, as far as I have seen the registry so far, is that the safety and efficacy are pretty well established also in the registries, especially with the Bigatran, the drug we know for the longest period of time. So the bleeding issues there are really also seen in the registry, the same we saw in the big RELY trial.
And do you think, Jean-Yves, that we need to have all of this registry data? I don't know how many we've got for non-VKA oral anticoagulants, but my guess is that there are 20 or 30 registries which have been set up looking at each of the NOACs in turn.
I think it's useful, yes. And we need all this information. I will take an example. Paulus has shown the results we have observed in PREFER, in which the proportion of anticoagulated patients is rather high, 80%. And but when we look where we have done this registry, it's clear that we have done the registry in cardiologists. And almost all the inclusion were made by the cardiologist. And when you go to other registries, for example, Garfield, which is all over the world, global one, you see that the rate of anticoagulation is lower. And clearly, if we have been able to convince a majority of cardiologists of the interest of anticoagulation in atrial fibrillation, it's not the same for GPs, for example, in many countries. And in Garfield, the total proportion of anticoagulated patients in the first cohort was rather not higher than 50-60%. So it's why I think that, yes, it's important to have all this registry and to be able to analyze exactly where they have been made and to see the results and to interpret the results taking into account this point of the country, the GP, neurologist, geriatrician versus cardiologist. That's important.
So we get information about the different settings in which NOAC drugs are being used, and we get an idea of the uptake of NOAC therapy. And as we were all saying, I think we get a lot of improved safety information because large numbers of patients are involved. But efficacy is very difficult to assess.
Efficacy is probably not the task of a registry to be found. But I think I want to make 2 points regarding registries that I think they need interpretation because we need to know where they are done. We need to know what are the inclusion criteria, who are the recruiting centers. As Jean-Yves said, some registries are run by cardiologists, some registries are prevalently run by internal medicine doctors or family doctors. So we have different views of the landscape. But this view is essential because a clinical trial will not give you the snapshot of what's going on. And I think there is another important aspect by which registries are important. They can give you some clues on why the advice coming from clinical trials are not taken in clinical practice. I give you one example. Paulus said that the use of aspirin is largely discouraged according to the guidelines based on trial data. And yet we have a high proportion of patients coming from registry data that still are treated with aspirin. Either aspirin alone or aspirin in addition to anticoagulants. which creates the problem of overlapping of antithrombotic drugs with increased risk of bleeding. Registry data can give us some clue on why this happens. And for example, the experience that we had in the PREFER registry analyzing the appropriateness according to the guidelines or inappropriateness of the use of aspirin disclosed that this is mostly due to the fact that doctors treat vascular disease and atrial fibrillation as two independent entities. So they have a kind of automatic reflex of giving one drug for one situation and the other drug for the other situation, with the outcome that whenever you have coexisting of two diseases, which is quite often happening in vascular disease and atrial fibrillation, two widely prevalent diseases, you have the coexistence of drugs, which is to 60 to 70% inappropriate according to our analysis that we gave. And this is information that may only come from a registry.
Marco, I'm very interested in the fact that we have at least two completely different forms of registry. One is a system that is set up specifically to look at what happens to the use of and the complications of a specific drug. So the registry exists only for that sort of purpose. And the other kind of registry is a large administrative database from which you can take this information if you like. And I don't know if there's any pros and cons to these different kinds of registries. Do you favor one over another?
So I think with these large efficacy trials, the question is always how can we translate to real-life data? And the registries we discussed, I think, merely show how we treat patients, if we treat according to guidelines, and if we, I truly believe we need outcomes. So pragmatic trials, preferably randomized in a daily care setting, I think are desperately wanted. And I'm also, when translating these efficacy trials to real-life data, the question is always, will these new drugs, or NOACs in this case, perform as well as they did in the phase 3 trials? And there are some smaller registries who looked at this, so they were not randomized. They were registries looking at, there is a German Dresden registry where patients on a NOAC were followed, and interestingly enough, what you see is that, and they were looking only at safety data, and interesting, you see that the performance in safety in major bleeding is the same as in the phase 3 trials, and even more interesting to me is that something I didn't expect maybe is that the vitamin K antagonists perform worse than they do in the real life data, and probably we all have had these discussions in our own nations that, of course, our anticoagulation clinics perform better than in the phase 3 trials, but that's not what we see in the registry. So, on the one hand, you see the NOACs perform, for safety standpoint, perform as they did in the phase 3 trials, and the vitamin K antagonists do not perform as well, or in other words, the treatment, the time and therapeutic range isn't as well regulated as it is, obviously, in the phase 3 trials. So I think we need more information, and I think randomized trials within registries or trials in a daily life setting without other interventions are something we need to look forward to.
So I think in summary, we think that registered data is complementary to clinical trial data, and it's also in many instances confirmatory of clinical trial information, particularly on the safety side. And in addition to that, we have all this information about how the drug is being used, what the uptake of the drug is, what the differences are between different healthcare settings, and so on. So registry data is being extremely helpful in rounding off our views about the non-VKA oral anticoagulants.